our speakers will stay for a few minutes to answer any questions.
For us about quality of life, and I think that I took that to heart. There's just a natural difference, though, between quality of life perception on patients who have anosognosia from like a right hemisphere stroke. Is that simply baked into the quality of life, or do you all have any controlling for right versus left hemisphere? I think it comes up a lot when we're in the unit and we talk about, is this a left hemisphere patient or a right hemisphere patient? Can you talk to us anything about that part?
I don't know if this is working. Is it? Mm-hmm. Okay. Yeah, no, absolutely. That's a fantastic question that definitely adds another dimensionality to all these assessments. The issue is really whether we are looking at standardized measures for quality of life, or how much are we allowing for an individual perception within that quality of life. And the balance that we have to strike is between those two forces, because in research, I'm probably guilty of doing this more than anyone else in this audience, is to standardize everything, because we want to measure across and we want to understand that what happens with a patient who has an MRS of 4, what happens on a right-sided patient versus a left-sided patient, right? And then the nature of research is that we do the whole thing of research to generalize our findings. We study a sample, we want to generalize it on a population, and then we say, well, right-sided patients behave in this way and left-sided patients behave in this way. And there are measures, quality of life measures, that have looked at that, but as I was trying to emphasize, is that most of that research has been done on indirect measures. So for example, if we look at EQ5D and MRS, the domains that we are assessing are so overlapping, because in that quality of life assessment, we are making so many assumptions. We are making an assumption that a person who cannot get up from bed and button their shirt and comb their hair are going to have a poor quality of life. And in most situations that there may be some correlation there, but I think when we talk about true valuation of life in the more direct measures, that is a very identity-driven, values-driven concept. And I feel studying that with left versus right-sided patients will be very interesting if there is a difference over there. But I think in that kind of valuation, there are much more fundamental, humanistic values, identity-driven things that drive that assessment. So that's where I think the challenge is with quality of life, essentially to be able to standardize it versus individualize it. Yes, absolutely. I'm in the line of fire today.
Of the quality of life scales that we have, how many of them incorporate caregiver type issues, caregiver burden, caregiver quality of life, and how appropriate do you think that is in the overall scheme of things?
That is an excellent question, and the short answer is not many. None that has been at least standardized and put into research practice. And I think it is extremely important. My personal research team's experience when we enrolled our cohort across Texas in talking to these patients, sometimes, most of the times, when we would pick up the phone or bring them in and talk to them and say, what is one factor after ICH that is troubling you most? They would usually say that my better half or my caregiver took a leave of absence from their work, and that is going to expire in 14 days. And I don't know what am I going to do after that. So you ask them, what is the one factor that we can change to help you? Most patients wouldn't say that I can't get out of the bed and I can't walk, or most patients wouldn't say that I need to walk with a walker and that is my issue, or I can't fix myself a sandwich, that is my issue, or I can't balance my checkbook, that's the issue. Because those are the kind of things that we do in MRS, and that's what we assume that affects their quality of life. But the caregiver aspect is so important, and it comes up so frequently. I would say 75 to 80% of the patients tell within the first 30 days that's their primary concern, that what is going to happen to their caregiver social structure. And there's been work that has been done that talks about social structure and how that influences outcomes. So I think it's an extremely important question that none of the scales that are widely used address that.
So just a question from the audience here virtually. So within a system, how should resources be allocated for primary stroke care versus comprehensive stroke care?
You know, I think it kind of goes back when you think about the guidelines and their recommendation, it's just a reminder that everyone is part of the team, is recognizing there are certain things that definitely belong just in the tertiary care center. And for example, the things that came to my mind was cerebral angiogram. You know, cerebral angiogram, you need the equipment, you need the people who have the expertise, and that's probably not ever going to be available everywhere. You know, I think there's so many different ways to look at this question, but that's one of the examples that's definitely something that would be streamlined. But again, every single person has a role, and there's no saying this absolutely should not be at this facility or this should be at this facility. Everyone has a role, but it's probably limited mostly by just what's actually available. And then there's one other question about early mobility and how it can be detrimental in the acute phase of ICH. And the question is that only in the ICU setup? And I think this is a really important thing when you think about guidelines, that guidelines are a starting point. And guidelines are never a black and white rule, but guidelines are a starting point for which you can start to think about your patient. You know, every patient, whether you're in the ICU or on the stroke unit, you can't put all ICH patients into one box. There's a whole spectrum of what ICH looks like, both on imaging and clinically. So I think the important thing with that guidelines was there was a study, which they're actually investigating in a more detailed study right now, which showed that in the first 24 hours, aggressive therapy led to worse outcomes. And they weren't sure whether that was frequency or whether that was intensity of the interventions, early rehab interventions in the first 24 hours. But again, there's a study trying to better understand that right now. But it's really just using the guidelines as a starting point and considering that what does your patient look like and what can your patient tolerate? But just know we have data to say there can be extra risks for these people.
Thank you, Dr.